dysfunction with raised LA pressure. Her aortic valve was normal with normal CW Doppler pattern. And she had again a whip of tear gradient was 14, IVC was normal in size, collapsing normally with respiration. So she didn't have pulmonary hypertension. I did the speckle tracking echocardiography where I got a low GLS of minus 15%. So if I sum up the findings in this young lady with history of syncope, 2 episodes of syncope, having left bundle branch block in resting ECG, but I got echo findings of dilated LV, septal thinning, wall motion abnormality not fitting in classic coronary distribution, systolic dysfunction of the LV, and low GLS. So what is the diagnosis then? Not fitting into the coronary artery distribution, and why should she have syncope? Now, since she has given history of dry cough for 4 months, we did a lung function test, which showed a restrictive pattern, and HRCT showed ground glass opacification with multiple nodules in the mid and the lower lung zones, increased reticulation, and mediastinal lymphadenopathy. All these features are suggestive of pulmonary sarcoidosis. So, a diagnosis of pulmonary sarcoidosis with probable involvement of the heart was made, and to confirm the diagnosis, cardiac MRI was done, which showed again basal to mid septal thinning and late gadolinium enhancement, showing the scarring in the mid myocardium of basal and lateral segments, and also in the epicardium. So, sarcoidosis. She is a patient of sarcoidosis, and a multi-system inflammatory disease of unknown etiology, characterized by the presence of non-caseating granulomas, and it can affect almost every organ system, though the lung involvement is more common with incidence of more than 90%. But if we look at the incidence of the cardiac sarcoidosis, though the incidence is said to be 2.5% only, but this might be only the tip of an iceberg, because autopsy studies and modern cardiac imaging, there's the MRI, suggest much higher incidence of 20 to 30%. So then we are missing a disease which has a very worse prognosis when there is involvement of the heart, accounting for more than 2/3 of the global death in sarcoid patient. So the cardiac sarcoidosis we are missing, there is no doubt about it. We need to be more vigilant. We miss because there is variable location of the sarcoid lesion in cardiac sarcoidosis, though commonly it involves base of the IVS, conduction system, LV pre-wall, and very rarely the valves, coronary arteries, and the pericardium. Because of this, there is a wide spectrum of clinical manifestation in cardiac sarcoidosis. It might be just a patient might present with benign symptom of palpitation or even a clinically silent, but usually the commonest presentations are due to arrhythmia, even sudden cardiac death, or myopathy, where a patient presents with life-threatening signs and symptoms of the heart failure. And death is mostly due to the ventricular arrhythmias, because the heart failure is treatable nowadays with present anti-failure treatment with option of cardiac transplantation, but it is the arrhythmia which is of major concern in cardiac sarcoidosis. If we look at the ECG findings in cardiac sarcoidosis, most commonly we get the AV block in the form of first degree to complete heart block, bundle branch block, as happened in my patient, and also the ventricular arrhythmias, maybe sustained or non-sustained VT or just simple VPCs. Even there may be supraventricular arrhythmias in the form of PSVT, atrial ectopic, atrial flutter, fibrillation. PET scan can detect with high sensitivity, but cardiac MRI is the technique of choice always. So now if we look at the echocardiography in cardiac sarcoidosis, what do we get? We get wall motion abnormality, not fitting in the coronary distribution, dilatation of the LV, systolic with systolic and diastolic dysfunction, RV dilatation, hypokinesia sometimes, low GLS. But to a price, it can be absolutely normal. No wall motion abnormality, normal ejection fraction. So if it is so, then echo is an insensitive technique to detect the cardiac sarcoidosis. With normal EF and wall motion abnormality, we cannot just rule out the presence of cardiac sarcoidosis. Then why do we do echocardiography? If it is not so sensitive, it is an insensitive technique, then why do we do? Well, it has got some role, because you can start suspecting the cardiac sarcoidosis if you get some positive echo findings, especially in the cases where there is a prior history of non-cardiac sarcoidosis or new and unexplained AV block, atrial or ventricular arrhythmias, and LV dysfunction. So active screening of such patients where we have clinical suspicion will help us with the echocardiography for early diagnosis of cardiac sarcoidosis, and treatment can save many young lives. Thank you.